Welcome to this video. My name is Pedro Rodrigues Ribeiro. I'm a psychologist from Portugal, and today I would like to share some thoughts on a specific psychotherapeutic model, a model called Metacognitive Therapy. Now, Metacognitive Therapy, or MCT for short, it's not really a true integrative model in the sense that MCT is an evolution of known cognitive models like cognitive therapy, like cognitive behavioral therapy, rational emotional behavior therapy, and so on. So it's not as integrative, but an evolution of these models. However, recent applications and research of approaches utilizing the MCT concepts are really integrative in the sense that authors like, for example, Giancarlo Dimaggio utilize experiential techniques and approaches into MCT. So MCT became integrative, although originally it's an evolution of cognitive models. So metacognitive therapy was developed by Adrian and his colleagues after they identified a common set of processes in patients suffering from psychological disorders. These identifications were done in laboratory conditions. So MCT is a research-based model. So the approach was developed from attempts to explain laboratory findings on biases of attention and reconcile these with clinical observations of patients who described particular styles of processing as a means of coping. So MCT originated by the comparison in laboratory findings and clinical observations of patients who suffer from psychological disorders. Now, metacognitive therapy, as the name implies, is a cognitive model. So one of the main focuses of metacognitive therapy is in cognitive processes and ways of thinking. So what were the processes that, or the particular styles of processing that Adrian and his colleagues found? The processes were excessive self-focused attention, attentional biases, worry, and rumination. Some of these processes were found in cognitive therapy and rational emotional behavior therapy. But what differ from those kind of models is the concept of metacognition. So metacognition is a concept that wasn't created by Wells. It was a concept that very researched in developmental and social psychology, but it hasn't had clinical applications as much as psychotherapy applications. So what is metacognition? Well, metacognition, simply put, is cognition applied to cognition. So it's a way of thinking about thoughts. And thinking requires metacognitive factors that monitor and control it. So I'm thinking about thoughts and how to monitor and control these thoughts. So that's what metacognition is. The foundation for metacognitive therapy and the generic basis of disorder-specific metacognitive models is the self-regulatory executive function model. This model was created by Wells and his colleagues to explain how people developed psychological disorders in terms of metacognitive therapy. So this model is it's essential to the case conceptualization of metacognitive therapy. So in MCT, maladaptive thinking styles refer to a preponderance of verbal conceptual activity that is difficult to control and occurs in the form of worry and rumination. So I have a specific thinking style that is preponderant on my verbal activity, and this thinking style occurs in the form of worry or rumination. Well, I'm always ruminating of a certain idea, certain thought, and obviously I'm worried about it. So these styles can be identified independently of their content, so they are content free, as intended forms of brooding and dwelling and analyzing information. So the way that I analyze information and I dwell and I think about it originates these ruminations and these worries in these thinking styles. So different to other models, I can extract the content, the context, the situation, because it's my thinking style. It's not context dependent. My thinking style is the process that distorts the information that occurs in the context. So, in contrast with standard CBT that focuses on the wide range of beliefs about the self in the world and says little about metacognitions, MCT gives metacognitions and metacognitive beliefs a central role in psychological disorders. So, in terms of standard CBT and cognitive therapy, as was conceptualized by Beck, the thinking styles, the metacognitive processes were not essential to psychological disorders or the origin of psychological disorders. In contrast, MCT believes that these metacognitions, these maladaptive thinking styles, are essential to the origin of psychological disorders. And those concepts and this importance on metacognitions and maladaptive thinking styles are essential to case conceptualization. As I said before, metacognitive therapy is a research-based intervention, so there is a case formulation structure developed by Wells and his colleagues, essentially to anxiety and depression, but you can generalize to other psychological disorders. Dimaggio and his colleagues have done that in two different psychological disorders. So applying the case conceptualization is the first step. So in terms of interventions, what are some of the techniques that the MCT therapist utilizes, or what is his or her objectives? So some techniques are shifting to a metacognitive model, metacognitive mode of processing. So shifting to another metacognitive mode of processing information, different from my maladaptive style of processing the information. Modifying negative metacognitive beliefs. Modifying beliefs is one of the same approaches that cognitive therapy and rational emotional belief therapy, behavior therapy, and CBT, they all tend to modify beliefs. In this case, is not the belief itself, but it's the metacognitive belief. So it's the way that I'm thinking about my belief. Also, modifying positive metacognitive beliefs. Sometimes it's necessary to modify also positive beliefs. Worry and rumination postponement. So I postpone or I freeze my tendency to worry and ruminating from worry and ruminating from certain thought. I can do that by doing some attention training techniques or implementing detached mindfulness. So it's the way that I can stop, or I can control or postpone the worry and rumination that it's in my head, so to speak. Also, I can do situational attentional refocusing, as I try to explain along the video. Metacognitive therapy and some metacognitive styles of thinking originated by certain attentional biases and attention processes. So if I do some training on refocusing my attention, I can then change and work on my on the way that I think about certain things. Also, targeting, also working on meta emotions. Now, the MCT as standard CBT and standard REBT focuses a lot on thinking and thinking, processing, and thoughts. So it's not so emotion focused as other interventions. However, nowadays we realize the importance of emotion in processing, because attentional process and thought process is different from emotional process, and those styles of processing, each and one of them affects the way that we feel, that we think, and we act upon certain conditions. So emotions as thoughts are important to psychological disorders, and nowadays with the evolution of MCT, integrating experiential techniques, emotions are more dealt with than the original MCT conceptualization. But when Wells and his colleagues developed MCT, they realized that it's important to address the way that we that we think about our emotions, and which significant that we attribute to certain emotions. Also, metacognitively focused exposure, and finally develop new forms of processing. These are some examples of techniques that we can establish in MCT. As I said along the video, nowadays with psychotherapy integration, a lot of authors, like for example Giancarlo Dimaggio, have expanded the MCT to other psychological disorders, and also the way that Dimaggio approaches MCT is more experiential than the original MCT. So he integrates a lot of guided visualization, a lot of chair work from CBT and Gestalt and emotion-focused therapy. So the way that MCT is done nowadays, it's more integrative than the original conceptualization of MCT. So I will link a reference to MCT so you can explore more about metacognitive therapy. I thank you for your time, and I wish you a great day and great days in health and safety. Please be safe and healthy, and I'll see you in the next time.